Good evening. Thank you so much for all of you being here. Today I picked the topic of opportunistic infections in HIV and AIDS, and throughout the program I will be asking you questions, and I want to make this session very interactive. So at any time, please feel free to stop me, raise your hand, and we'll make sure that we'll address all of your concerns. Any questions before we begin? I guess most of you know me. My name is Beata Casanas. I am assistant professor with USF Division of Infectious Diseases in Department of Internal Medicine. I'm also a medical director of the Hillsborough County Health Department and in charge of the tuberculosis clinic. So if you have any questions even not related to today's lecture, you are welcome to ask me anytime. So to get started, how do we define opportunistic infections? We look at the stage of HIV, we look at the CD4 count to determine what kind of infections are more likely to be presented in our patients. We determine the prophylaxis for opportunistic infections. We look at the CD4 count to see when is the appropriate time to start HIV therapy, and of course for the definition of HIV. As you guys know, one definition of HIV is CD4 count less than 200. But can you have HIV AIDS with normal CD4 count? Yes. And how does that happen? Okay, so if you have an opportunistic infection or what it's called AIDS-defining illness, you will have AIDS. How is it possible with high CD4 counts for you to get opportunistic infections? Let's say you have a CD4 count of 1,000. How is it possible that you are getting oral Candidiasis? How does it work? How can you get this with normal CD4 counts?
If you're co-infected with HCLV1.
What if you're not co-infected with HCLV1? Any guesses?
It's a functional?
Exactly, it's a functional approach. So basically we have two definitions of AIDS. One of them is based on CD4 count, and a second one is based on functionality of your CD4 counts. So yes, you can have a CD4 count of 1,000, but if your floating CD4 cells are not functioning, you will get opportunistic infections. And that's where the definition of AIDS-defining illnesses come from. Any questions? So just to give you an idea, what are we looking for with different CD4 counts? As you can see, with CD4 count above 300, you can get strep pneumonia, you can get tuberculosis, you can get lymphadenopathy. Usually with CD4 count less than 200, that's where esophagitis, candidiasis, thrush, PCP, Kaposi, sarcoma comes from. And with CD4 counts less than 100, that's when we look usually for lymphomas, Toxoplasmosis, zoster, PML, CMV, and MAC. So I want to go system by system through the pulmonary system, nervous system, and GI system and discuss all of those diseases in order, just to give you a baseline for you to build on in the future. Starting with PCP. As we all know, it's very hard to diagnose. Patients usually present quite hypoxemic, it's very insidious. You may or may not have anything on a chest x-ray depending on the patient's CD4 count. If the CD4 count is too low, the patient is not going to be able to make an infiltrate, so you may have a negative chest x-ray, even negative a CT scan. The CD4 count is usually very low, and you're going to have elevated LDH in majority of the cases. Silver stain of a sputum or the BL for diagnosis is rarely positive. In majority of cases, you do need bronchoscopy to get a really good sample. So if you order the silver stain of a sputum and it's negative, by no means does not mean they don't have PCP. If your index of suspicion is high, you always veer on a side of caution and you go ahead and treat. Just to give you an idea on this picture, do you see you have a little bit of alveolar? I don't know how well it's projecting on the screen. You have a little bit of alveolar, really nothing you would be worried about if the patient was HIV negative. So it could be very, very insidious or even totally negative chest x-ray. What is the treatment? As a review, Septra is the drug of choice. If they cannot tolerate PO doses, you use IV. PO doses are 2 double-strength tablets 3 times a day. So it's 6 times the prophylactic doses of Septra. In patients who are allergic to sulfa, what is the second drug of choice? Huh? What's the difference between Septra and atovaquone and Dapsone? I guess let me pose the question. Because usually for sulfa allergic patient, the next drug you go to is Dapsone. Why would you go from Septra directly to atovaquone? Besides sulfa allergy, why would you skip Dapsone, I guess, is my question. There's a point number one, there's a 50% cross-reactivity between Septra and Dapsone. Number 2, Dapsone does not cover toxoplasmosis, which Septra does, and atovaquone does. So before you switch patients from Septra to Dapsone, make sure their toxo IgG is positive already. Because if it's negative, you would go straight to atovaquone. The problems we are encountering with atovaquone and why it's not an immediate choice after Septra is because it's PO and it's quite a difficult taste. It's a liquid form for patients to tolerate every day. So if we can, if a toxo IgG is positive, we go from Septra to Dapsone. And if the toxo IgG is negative, we'll go to atovaquone. Remember, pentamidine IV or inhaled is the 4th option. We usually leave it lower down because of the side effects. There are several side effects which are related to the IV infusion of pentamidine. And the inhaled is only used for prophylaxis and it's only used once a month. So sometimes it's hard for a patient to keep compliance coming in every month for inhaled pentamidine. Also, when do you use steroids with HIV/AIDS patients and PCP? When your AA gradient is? It's actually 35, Or your PaO2? Less than 70, exactly. So the best way to determine it, if you're seeing the patients in an ER, make sure you get an ABG. Why wouldn't you automatically put HIV/AIDS patient on steroids if they are presenting with cough and upper respiratory symptoms? Because it would be so much easier, right? Just put everybody with the PCP and then taper them off. What would be the one reason you wouldn't automatically put an HIV/AIDS patient on steroids with lung problems? Not only that, it's actually tuberculosis. Because remember, if an HIV patient comes in with a cough, you have to rule out TB. And what happens when you give steroids to the tuberculosis patient? You just move the disease from the lungs into a disseminated form. So that's why we don't automatically use steroids up front. We want to get the indication, get the ABG, and then, if necessary, by all means do it. Or at least wait if we can at least get a 1 AFB sputum negative to make sure they don't have overt tuberculosis. What's the prevention? Just like we discussed, it's Septra. We have 2 types of prophylaxis, primary and secondary. What's primary? When they've never had PCP before and their CD4 count is less than 200. Secondary means they had PCP before, and that's the number 1 risk for getting PCP. That's a board question. Previous PCP is the number 1 risk for a next PCP to occur. So they love to ask that question almost every year on the boards. And of course, when would you discontinue the prophylaxis? If you have a CD4 count above 200 on 3 separate occasions. So it's not that the question comes up in our clinics, the patient's CD4 count is 201, can we stop it? Or, it's 250. Well, let's see if this is something stable, or at least let's see above 200 for 3 months before we change and stop the prophylaxis. Any questions? I think the question was, is it always 3 months or is it 3 separate occasions? I think different sources will give you different opinions. The point of it is not an exact number, how many times you need to see it or how long. You just want to make sure that the above 200 is not a lab error and it's just something stable and their CD4 count continues to climb up. And it's just not a one-time blip where they have over 200 reading and then they are back, in the prophylactic. So you just want to see a stable CD4 count. I don't think the exact number matters, above 200 for an extended period of time. Next, I want to move into the nervous system, talking about HIV patients coming in with neurological symptoms. You do a CT and you have a brain lesion or brain lesions. This is just a quick guide as a review for you guys. When do you think about toxoplasmosis? When do you think about lymphoma? So, of course, if your toxo IgG in your blood is positive, it's most likely toxo. If you have multiple lesion versus single lesion, that's most likely toxo. No septra therapy, that's really subjective because the patients may be on it. The question is, have they been taking it? So you really have to be honest with the patient and truly ask them, have you been really taking your prophylaxis? And of course, if we have a single or multiple lesions, even if they are not ring enhancing, the first treatment is treat for toxo, at least for a week. Repeat the CT because if it's toxo, you already should see improvement within a week or so. If there's no improvement, they need a brain biopsy because it's probably lymphoma or something else. If there is improvement, you continue treatment until resolution. So then you probably treat for another couple of weeks and wait for a repeat CT or repeat MRI to be clear before you stop therapy. And this is the classic appearance of the ring-enhancing lesions, as you can see. Treatment and prevention. Treatment, sulfadiazine, pyrimethamine, and folinic acid. They love to ask this on the boards. It's not folic acid, folinic acid. Remember, you always have to repeat the MRI to make sure that the lesions are getting smaller and to document resolution so you know when to stop therapy and switch them to secondary prophylaxis. Maintenance therapy after your induction phase. And of course, if the patient has any neurological symptoms, you know you have to use steroids and anticonvulsants if necessary. We already mentioned that Septra is adequate prophylaxis for toxoplasmosis, but if the patient has not been exposed to toxoplasmosis, we have to go to atovaquone because Dapsone does not prophylax for toxo again. So repetition. Cryptococcal meningitis. Very difficult to diagnose. Unless the patient comes in with this horrible headache and they will describe it to you. This is the worst headache of my life. You think they are having subdural hematoma. You do a CT of the head and it's negative. And of course, headache in HIV patient equals LP. When you do LP, you have very high opening pressure. You're going to have a cryptoantigen positive in the CSF and majority of the cases in the blood. Usually you're going to see some lymphocytic pleocytosis and the India ink is going to be positive. This is just the appearance. They love to show pictures on the boards. One thing for you to remember, very, very thick. Nothing else has such a thick capsule as Cryptococcus. So if you see anything with a very thick capsule around it and it's a fungal question, it's Cryptococcus. Treatment. You start the induction phase for the first 2 weeks with amphotericin B, Abelset, Embisome, any of the ampho compounds, and 5-flucytosine as in conjunction therapy. And after 2 weeks, you can switch to fluconazole for the maintenance therapy for another few weeks. What's important for you to remember is that I recently had a case of amphotericin B resistant Cryptococcus, and I had to have the lab repeat their sensitivities, and it came back several times resistant. So be sure that if you have availability in whatever hospital you are ordering in, that you can follow up on the sensitivities. Don't just automatically assume it's going to be ampho sensitive. So what we did in my patient, we actually went by the sensitivities and used IV voriconazole during the induction phase and then switched them to a POV fen because that was the only thing that the patient was sensitive to. So I assume, probably our hospital is not the first one to see it. Probably somewhere else in the country will have those cases come up. The more we use drugs, resistance is coming. What's the treatment for the headache in cryptococcal meningitis patient? Repeat LPs. You may end up doing them every day for a week. And the patient will tell you when they don't want the LP, they are feeling better. But the headache is so bad, the patients will actually ask you, for the LP. That's how devastating the headache is, and nothing else works. It's just the buildup of the pressure which causes the headache, which no pain medications truly take away. CMV Retinitis, just want to mention it. In our patients, the eyes are not just the windows to the soul, but also to our nervous system. So if you want to see a CMV involvement, definitely if any suspicion of vision changes, ophthalmology consult. Usually is seen with lower CD4 counts, definitely an opportunistic infection, and usually treatment is with induction therapy with both drops and IV therapy with either ganciclovir, foscarnet, or cidofovir. What's important about ganciclovir and foscarnet or cidofovir, make sure you check daily electrolytes, especially magnesium, calcium, potassium, and phosphorus. Because just like with the ampho B components, especially with amphotericin B, these are depleted on daily basis. So you need those electrolytes to be ordered every day. Okay, Mycobacterium avium complex, very hard to diagnose. A lot of cases I end up treating empirically. You can order AFB blood cultures. Usually you see it with a low CD4 count, but usually patients come in feeling bad, feeling weak, and having fevers. And there is really not an organ that you can directly go into. If you cannot really diagnose it anywhere and the empiric therapy is not working, and a patient, especially if a patient is pancytopenic, meaning that if they are anemic, their platelets are low, their white blood count is low, what would be the test you would go for to get the diagnosis? Bone marrow biopsy, exactly. So if at loss you cannot diagnose it in the blood or anywhere else, the patient doesn't have any local symptoms, like to do a liver biopsy or the biliary tree where MAC likes to hide as well, you would proceed to bone marrow biopsy. And usually with pancytopenia, that will be the place where MAC can be diagnosed from. You can do a CT of the abdomen, but it's really very non-specific because the retroperitoneal lymphadenopathy, any infection can cause it, HIV alone can cause it as well. And usually the hallmark is just a low CD4 count and fever. What other two diseases you would look for in a patient like this besides MAC? Histoplasmosis, exactly the same presentation, and CMV and Cryptococcus. Before it gets to your CSF and causing the high pressure and the headaches, if it's just a bloodstream infection, will only have spiking fevers. So really when you see patients with HIV or on your board questions, make sure you think about urinary histoantigen, Cryptococcus antigen in the blood, and of course AFB blood cultures for MAC in the blood, and a CT scan just to make sure you don't have any masses or cryptococcomas. You can have a whole mass of Cryptococcus in an organ sitting, something which could be even biopsied. Diagnosis and treatment, just like we discussed. As with any mycobacterial infections, remember always you need more than one drug. So it's going to be minimum 2 medications. In case of MAC, azithromycin and ethambutol. They can be given PO, we already mentioned, bone marrow biopsy, and of course prophylaxis. You all know 1200 milligrams of azithromycin once a week. Important to remember about it, make sure the patients do not take it on empty stomach. It's very tough on the stomach. Imagine in our STD clinics when we give them the 1 gram azithro, on the spot. Now imagine this is even higher dose, so horrible GI upset. So make sure you explain, warn patients about it, make sure they take it on full stomach, because otherwise they're taking it at home once a week. If it's going to make them sick, they are not going to take it. I want to move to the GI complications of HIV. Oropharyngeal, esophageal, hepatobiliary. I want to show you some pictures. So when you are rounding, when you see the patients, I want you to be able to recognize it as well as on the pictures on the boards, because some of them can be tricky. So oropharyngeal, what are we talking about? You can have candidiasis, you can have the oral hairy leukoplakia, any periodontal or ulcer disease, and of course don't forget Kaposi's sarcoma. Oral candidiasis, we see in immunosuppressed patients, not just HIV or AIDS. Did you guys know there is actually 4 types of candidiasis? It's not just the proverbial thrush. Number 1, pseudomembranous oral candidiasis. And you can definitely later on take a look at pictures at the screen, and I'll give you you're going to have access to the copy of a lecture so you can see the original pictures. So it just looks like pseudomembranes on the oral cavity, and they can be scraped off. We are always taught we can scrape it off. It's usually candidiasis. You can have the erythematous oral candidiasis. All it is redness, no thrush, no white stuff, just redness, and it's also fungal infection. Smooth red patches. Angular colitis, just the little cracks on the side of the mouth. It's not just vitamin insufficiency, as we've been always taught. Candidiasis alone can cause it, fungal infections. And hyperkeratotic oral candidiasis. This is something that I have seen several times. I don't know how many of you have seen it. And usually, probably, if you have seen it, you will probably have gotten a biopsy just to be on a safe side, because it could be, of course, confused with oral hairy leukoplakia. So what's the diagnosis? Yes, you can use KOH, but it's clinical. Majority of the cases we treat it based on a clinical basis. What can you use? Clotrimazole, nystatin, fluconazole, itraconazole. If I use fluconazole, I like to use higher doses. Probably start at 200. Another drug, as you know, you can use candidiasis. What was the advantage of candidiasis over fluconazole? Because of a fungal resistance. After candidiasis, mycamine came. What was better of mycamine from candidiasis? What was the advantage of mycamine? No dose adjustment. So regardless of the renal insufficiency, and especially in transplant patients where we use mycamine, it was great because you didn't have to worry about drug interactions with other meds. Another med came out, Eraxis. What's different about Eraxis, which is another echinocandin? Because each of them has a niche, and I just wanted to make sure that you know in which places we would be using them. Exactly. It doesn't go neither it does not go neither through the kidneys nor the liver. It's biliary excreted, so there is a niche for the drug is in patients who are both in renal and kidney failure, because you don't have to adjust for either, and it's excreted in the bile and your GI tract. Okay. And treatment, of course, amphotericin B, but very few of us now with having echinocandins, very few of us would use amphotericin B to treat oral candidiasis, because the side effects are just too great. Duration of therapy, this is one opportunistic infection. Another board question is that you do not prophylax for, you only treat when it's there, and you stop treatment when it disappears. Do you see how different it is from all of the other opportunistic infections? Therefore, intermittent therapy, chronic suppressive therapy is really not recommended, because, as you know, especially with fluconazole, liver is affected and you don't want them to be on it long term. Oral hairy leukoplakia, what I need you to remember that it's caused by EBV virus, Epstein-Barr virus. It does not scrape off. That's another board question, how it's going to be different from the oral candidiasis. It's not a pre-malignant condition. That's the number one myth that we have to dispel. And really, targeted therapy is not recommended. Really, the treatment of choice is HIV therapy. You get the immune system up, and that's how you get this better. And this is how it looks. Do you see how easily it could be confused with the last type of the oral candidiasis? Oral ulcer disease could be anything. In cases of oral disease, you really need a biopsy. HSV is going to look just like CMV, just like Aphthous ulcers. What are Aphthous ulcers? Believed caused by HIV itself. What is the drug of choice? They love to ask it on the boards. Something that in real life you would rarely use. One of the drug of choices is steroids, but what is the board answer drug of choice for Aphthous ulcers, which we see and they are associated with HIV disease? Thalidomide. So there is a use for thalidomide. What's the other use of thalidomide while we are on board questions? Multiple myeloma and what's Hansen's disease? Leprosy. So remember, thalidomide, leprosy, multiple myeloma, and treatment of Aphthous ulcers in HIV. But really, in real life, we use steroids and they get better. But if you had a refractory case, thalidomide is definitely the drug of choice. Herpes simplex. Appearance, you guys know. What I need to warn you about is that may look different in very immunocompromised patients. They may almost look dermatomal. It's gonna be probably not as vesicular, not as beautiful, could be disseminated in an entire dermatome and still be herpes simplex virus. And this is the appearance, and we have all seen it. In the mucous membrane, looks a little bit different than on skin. So please have a high index of suspicion. If you see a picture on the boards, that's how I would look like. The multinucleated giant cells, or if they use the word multinucleated giant cells, they are talking of HSV. What's the treatment? If it's very bad, I usually jumpstart my patients with IV therapy, IVI cyclovir, usually 5 to 10 milligrams per kilogram IV Q8 hours. Then I switch them usually to Valtrex. Why not PO acyclovir? Because it's 5 times a day. And you can imagine the patient or even the nurses administering an antiviral medication 5 times a day. It's quite difficult. So Valtrex, you can switch to treatment doses with just 1 gram twice a day. If we're talking about VZV, varicella zoster virus, it's going to be 1 gram 3 times a day. So you just add 1 middle dose in the middle to increase it for PO therapy. And parenteral therapy, if you have acyclovir resistant herpes simplex virus, which we've had few cases, you can use again, just like for CMV treatment, IV cidofovir or IV foscarnet or IV ganciclovir. Any questions? CMV looks just like HSV, just maybe a little bit bigger ulcers, but clinically it's very hard to diagnose. That's why biopsy is again the standard of care for treatment, because the treatment is different. Acyclovir or any of the thymidine compounds do not work for CMV. And as you can see, the ulcers are a little bit bigger, but clinically they will look just like HSV. Treatment, just like we discussed with the CMV retinitis, again, repetition and review when you're looking at the lecture. Again, ganciclovir, valganciclovir, foscarnet, or cidofovir. Sometimes we add probenecid to decrease the renal toxicity. So if you see it on the boards, I want you to make sure that you are able to recognize it. Aphthous ulcers, again, we discussed steroids and thalidomide. You can order thalidomide through CDC directly. There's actually a number you can call. And do you see the appearance is almost identical for aphthous ulcers, CMV, and vesicular lesions, especially if the vesicle is not there any longer. It's really very similar. Diagnosis, again, biopsy and viral swabs. And we mentioned prednisone. Thalidomide dose, you would use 200 milligrams once a day.
You almost lost the power.
Wow. Periodontal disease. Very important, 2 forms that I want you to be aware of: necrotizing ulcerative periodontitis and linear gingival erythema. Want to make sure if you see it on a board, you are able to recognize it. And we've all seen our immunocompromised patients. And this is a source of bacteremias, this is a source of abscesses, this is a source of endocarditis. So if you see this kind of dentition, you need a panorex to make sure there is no abscesses, and look for endocarditis, both in real life and in a board questions. Okay? Linear gingival erythema, this is just the inflammation alongside the gum where the teeth are attached. What's the treatment? You can use any of the local chlorhexidines, metronidazole, Clinda works, because this is you're really trying to decrease the load of anaerobic flora in the mouth. Kaposi sarcoma can involve any part of the GI tract. Obviously, mouth is part of it. Usually it's symptomatic if you have oral lesions. In lower GI tract, you can get obstruction. And of course, what you need to know is associated with human herpes virus 8. Okay, very important. It will come up on your boards. In appearance, you would have these darkened patches on the back of the throat, or on buccal mucosa, or anywhere in the mouth. Usually lower CD4 counts, about 40% is visceral disease. What's the one disease that will try to trick you on the boards? Bacillary angiomatosis caused by Bartonella Hensley. So remember, Kaposi sarcoma, Bartonella Hensley. You can get IgG and IgM serum levels for Bartonella Hensley. What else Bartonella Hensley do besides bacillary angiomatosis? Cat scratch disease, and another manifestation, especially in the liver. Exactly, Peliosis hepatis. Make sure that you are able to associate Bartonella Hensley with those three presentations for the boards. What's the treatment? Sclerotherapy, HIV therapy, chemotherapy. Nothing really works well, but we try based on the location and extent of a disease. It's really patient-tailored treatment, but of course, always HIV therapy and boosting the immune system, works the best. Esophagitis could be caused by any of the diseases we already discussed. Candida, and this is the appearance, just like we discussed for oral candidiasis. The same treatment. Can you have a throat candidiasis or esophageal candidiasis without oral candidiasis? Absolutely. So just because they don't have thrush, if they are complaining of odonophagia, you will empirically treat them for candidiasis because it's really empiric treatment. If they fail fluconazole treatment, if they fail herpes treatment, that's when you need an EGD to look down and see if there is something else. Esophagitis, again, just like with the oral lesions, it's extension of the GI tract. We already discussed HSV, CMV, Aphthous Ulcers, and Kaposi Sarcoma. And do not forget about good old reflux, because in the boards, they like to mix the cough with GI disease. Not everything on infectious disease boards is infectious. So patients with cough, don't forget it's postnasal drip, could be reflux. Exactly, and that will be the response, that will be the right answer. So don't think, it can't be because this is ID boards and the answer has to be infectious. Okay, so don't let them trick you. Something I want to mention about AIDS cholangiopathy, that's something which presents with fever, right upper quadrant pain, nausea, vomiting, weight loss, and elevated alk fast. That's what you're going to get even on your board questions on the patient presentation. What can be caused by Cryptosporidium, CMV, and Microsporidium? In 60% of the cases, 40% of the cases, we have no clear etiology. How would you diagnose it? Probably through ERCP or biopsy. I just need you to be aware that this is a syndrome that, you may think this is cholangitis, this is maybe, what is right upper quadrant? In AIDS patients, Cryptosporidium, CMV, and Microsporidia can cause this acute cholecystitis, almost like picture. Cholangiopathy, how would you diagnose it? Ultrasound, just like mentioned. ERCP, what's the treatment? Usually the sphincterectomy for the papillary stenosis, biliary stents, and the treatment depends on what your cultures grow, what your serologies are, because it's different, just like we discussed for Cryptosporidium, Microsporidium, and MAC, the therapy is different. Liver disease, on the boards, of course, viral infections and opportunistic infections we are going to all think about, but don't forget medications. Don't forget Tylenol, don't forget urine drug screens, and looking for more obvious toxic causes of liver disease, abnormalities. And of course, now in the era of HIV medicine, you have quite a good experience in your clinics, HIV medications. Majority of them are metabolized through the liver, so make sure, especially if a patient comes in with any kind of liver problems to the hospital, I usually, as a rule, like to hold their HIV therapy. 2-3 days is not going to make a difference, but at least gives me a chance to see if their LFTs get better, give their liver a break, and see if I can get any answers from the workup. So the HIV therapy does not mix the picture. Liver opportunistic infections, mycobacterial disease again, repetition. Fungal infections, we already discussed all of them, and the good old Peliosis hepatis from Bartonella Hensley. What's the appearance of the Peliosis hepatis? On a CT scan, you will have a cystic blood-filled spaces in the liver. Just little packets, which may look like abscesses, but they are like a mini hematomas. They are just going to be packets of accumulated blood, not clotted, accumulated fluid blood. So you can see, you need to be aware of a syndrome so you do not go for the biopsy instantly because you can cause a serious hemorrhage. Liver biopsy, blood cultures, imaging studies, just like we discussed. Pancreatitis, Thank God we have new medications now, so we don't have to worry about the D drugs, the D4T, DDI, DDC, which were the major culprits of pancreatitis in HIV patients. But don't forget the good old alcohol is still a factor. And of course, the cholangiopathy can cause pancreatitis. And again, any of the opportunistic infections that we discussed with AIDS cholangiopathy are also the same infections causing pancreatitis in HIV patients. Good old diarrhea, 50 and 60% of our patients have it. What's the workup? You, of course, need stool studies for enteric pathogens, for ovan parasites. Why do you need the AFB of the stool for? Cryptosporidium and MAC, right? Mycobacterium avian complex and Isosporidium and so Cryptosporidium, Microsporidium, Isosporidium, and MAC, they are all AFB positive. So you can see you may not have to order all of those up front. You can just do one more Dr. Tony wants to ask you about. And what is cyclospora? The question was, if they are on sulfa prophylaxis, you will not see cyclospora in the stool. And what are they commonly on the old board question associated with? Raspberries. Remember, guys, the story is raspberries and cyclospora. They love to sometimes ask the questions as well. And of course, don't forget about good old C. diff assay. If fever, you know you have to order the tertiary workup of the blood cultures, every blood culture CMV, PP 65 for CMV. Salmonella, you guys all know, two types, Typhimurium and Enteriditis. Why do I pick Salmonella? Because they like to put it on the boards again with HIV patients. It's an AIDS-defining illness. This is one of those bacteremias which starts maybe in a stool, gets into the bloodstream, and it's an AIDS-defining illness. What is the treatment? Based on sensitivities, but fluoroquinolones, amoxicillin, even Septra works. Question on the boards, what is Salmonella known for causing in HIV patients? What kind of infections? What body part? I'm glad we're having this lecture. Osteomyelitis. Osteomyelitis. HIV AIDS patients, Salmonella, osteomyelitis. Not because of their HIV. It still is more common in the axial skeleton first before it gets to the joints. So it has not related to HIV, but just the fact that Staph aureus is usually in HIV negative patients. You can see a lot of Staph aureus in HIV positive patients, but Salmonella is second closest after Staph aureus in osteomyelitis. And you don't see it in HIV negative patients. Shigella, as you guys know, megacolon perforation, 50% chance of bacteremia. Treatment, the same as Salmonella. So even if you have a low index of suspicion, you're going to treat inadvertently, even if you don't look for it, because it's the same treatment. C. diff, that's a whole lecture in itself. As a review, you guys are experts at treating C. diff. C. diff, you know that flagell PO is the first drug of choice. If it fails, you repeat flagell PO again from 2 weeks to 3 weeks. And on the third run, you go to PO vancomycin. Why don't we use PO vancomycin up front? Because this PO vanco is the drug of choice for C. diff colitis. Why don't we use it up front? Because of resistance. You do not want to cause VRE. So that's why flagell is used as a first and second line therapy, and PO vanco is reserved as the third. MAC treatment we've already discussed. As a review for you and for diagnosis, less than 100 CD4 count, CT scan, treatment, azithromycin and clarithromycin. May have to add always clarithromycin or azithromycin, and always add ethambutol. What do you have to worry with ethambutol? Board question? Visual changes. Before you put patients on ethambutol, eye exams, especially color distinguish. Okay, very important for you to know. Cryptosporidium in the stool, fecal oral route. We already mentioned AFB, way of diagnosing it. That's how it would look like if you guys see a picture under a microscope. What's the treatment? Paromamycin, azithromycin, nitazoxanide, or now Alinia, one of the newer drugs. But nothing really works well. That's why we try everything. I guess the best, experience personally I've had with Alinia up to now. I don't know how many of you had got a chance to use it. Isospora belli, again, these are all the Cyclospora, Isospora, Cryptosporidium, AFB of a stool, just like Dr. Tony mentioned. Treatment Septra, 4 times a day for 10 days. And of course, pyrimethamine if you have sulfa allergy. On the boards, they like to give you allergy to the first drug of choice. So you really need to know at least the second or the tertiary drug of choice for treatment. And why is it called Isospora? As you can see, this is beautiful iso, meaning the same shape, almost kissing spores together. How romantic. Microsporidium, that's the smallest of them all. In HIV/AIDS patients, we have seen 2 that I need you to be aware of: the Enterocytozoan bianusi and Encephalitozoan intestinalis. It's found up to 50% of AIDS patients, and it causes these unexplained diarrheas, non-bloody, even to the point of having malabsorption, cholecystitis, cholangitis. So you can see how important it is to think of them, to order the right test, and to diagnose them. Diagnosis: small bowel biopsy or stool studies. Treatment is albendazole, and really for the Ibianusi, HIV therapy has been the best. For any of the microsporidial disease, really hard therapy is the drug of choice, because until you boost the immune system, this is really what it's going to make a biggest difference. AIDS wasting syndrome, we have to mention as one of the GI diseases. It's unintentional weight loss. AIDS defining illness in about 20% of the cases. Could be related to anorexia, depression, malabsorption, or just the HIV virus itself. What's the treatment? Anything we can stimulate the patient's appetite, from Megace, any oral supplements, TPN, if necessary, and resistance exercises have been also promoted. Anabolic steroids, we have an experience in our outpatient clinic, are also used for the weight gain. And almost all of our HIV patients should have their testosterone checked, especially in advanced AIDS disease, because HIV does lower your testosterone, HIV alone. It's totally not related to the patient's age. Pulmonary, degree of immunosuppression, underlying pulmonary disease. What's the exposure? What's the prophylaxis? We've already discussed how would you determine the etiology. You try non-invasive means. If they don't work, bronchoscopy, and of course biopsy. Usually the end result sometimes is even bone marrow biopsy. Respiratory specimens, you can have a totally different. Why do you need gram stains for your sputum, of cultures of the sputum? What does the gram stain tells you? Why do you need a gram stain when you order a sputum of a culture? Exactly. This is what the UA almost does to urine culture. You want to make sure that there's white blood cells in the UA for your urine cultures to make it valid. The gram stain just tells you if it's a spit or is it really good bronchial specimen, and how good it is if you have a lot of epithelial cells. So, empiric treatment in HIV patients. If the CD4 count is high, above 200, as a review, think of TB. Tuberculosis unrelated to the CD4 count. If less than 200, of course, community-acquired pneumonia with azithromycin, but also PCP. If patient able to swallow pills, double strength, Septra, 3 times a day for 21 days. Focal infiltrates, that's what you need to think of: bacterial, mycobacterial, fungal disease, and of course malignancies in HIV patients. Don't forget KS and lymphoma in the lungs. Diffuse interstitial pneumonias, PCP, H-flu, Legionella, viral pneumonias, and pulmonary toxo. Cavity abscesses, Mycobacterium. Always think Mycobacterium. What bacteria can cause, especially in HIV patients, cavities? Pseudomonas, Staph, Rhodococcus, and Nocardia. Aspergillus, famous for causing the cavities and the fungal balls. Usually, how do you diagnose it? Through a biopsy. And malignancy, always in the differential diagnosis. Nodules or masses, Mycobacterium, Cryptococcomas that we mentioned could be in any body part, fungal disease, granulomatous disease, and malignancies. Bacterial pneumonias, you guys all know, treatment would be as community acquired. Always look for each influenza. We like to order the Legionella and strep pneumonia urinary antigens. And in HIV patients, do not forget about Rhodococcus equi. They also like to ask it on the boards. Appearance of bacterial pneumonias depending on a CD4 count. If a CD4 count is high, they are able to mount and infiltrate. If there's a low CD4 count, you are gonna maybe have, just like with a previous, like with either CMV or PCP, you will have a negative chest X-ray. This is just the appearance of a strep pneumo. Infiltrates could be anywhere. I know it's a bit disturbing to have the flashing. I'm glad nobody is seizing yet. PCP, just we already discussed as a review for you as you're going through the lecture. And of course, with the hard era, the PCP, we see less and less and less PCP. Usually it's with non-compliant patients who don't take their HIV therapy, who don't take Verseptra prophylaxis, and again, very interstitial findings could present as anything on a CT, could present as anything. Treatment, we've already discussed. Prophylaxis as a review, this is the pentamidine, the dapsone, and the doses as a review, again, we've discussed. Non-tuberculous mycobacteria, if AFBs are positive, we always assume it's TB, but remember, follow up your cultures 8 weeks later to make sure it's not MAC or Mycobacterium candidiasis or another species. This would be the appearance. CMV pneumonias, that's something we usually see in transplant patients, but it's very possible also to see it in HIV patients. And again, diagnosis is by the CMV inclusions and from the BAL and bronchoscopy. Treatment, what's different about the CMV retinitis and CMV pneumonia? IVIG is also added to the treatment in addition to the antiviral agent. And usually the doses are milligrams per kilogram every other day for 10 days. And again, appearance is really very similar. I know it's hard for you to see on the screen, but even doubt, always bronchoscopy with biopsies is the best way of choice. And this is just a CT scan. If you can see, this is the appearance on the slide. That's something probably they will not show you on a board because there's nothing pathognomonic about it. You can also have a pulmonary cryptococcosis. This is an inhaled pathogen. It's not just in the bloodstream. You're going to usually have a miliary pneumonias, upper lobe lesions. Cavities are very rare. And again, meningitis is the #1 presentation. But if you see it in your BAL or in your bronchoscopy, it's not a mistake. You also can have cryptococcal pulmonary disease. Again, just like we mentioned, the same treatment as for neurological crypto. And appearance again, what's different, you see this is the Cryptococcomas, which looks almost like a fungal ball, almost like an abscess. It's going to be nicely isolated, and usually biopsy is going to be your definite mode of diagnosis. This is how it looks on a pathological slide. Pulmonary penicilliosis, that's something which is very distinct for HIV patients. They love to ask this question on the boards. They usually show you a patient of Asian origin and looks just like cutaneous cryptococcal infection. And that's penicilliosis, usually from Southeast Asia, China, Manipur, that use any of the regions on the boards, can cause infiltrates, nodules, cavities, adenopathy. And again, treatment, induction phase with the amphoby, you can switch to fluconazole or micamine, or go purely by, at this time and age, we can go by the sensitivity profiles. Pulmonary aspergillosis, we are all familiar. Again, fungus balls, we've already discussed, can cause nodules, pleural-based lesions, diffuse infiltrates. Usually histopathology is the gold standard, but what I need you to remember, you can also go by the galactomannan test and PCR. Treatment, again, you can start with amphoby, goes by sensitivities. You can use micamine, you can use Vfent based on the sensitivity. Some of the compounds come only IV, so use them for induction. Then again, you can switch to PO for maintenance doses. And again, in HIV patients, it would be really hard to diagnose it just from your imaging studies. And you can see the crescent sign, what they like to also ask on the boards in aspergillosis. Do you see why is the crescent? It's more of a half moon that you can see on the CT. And this is how it would. They may show you a slide because you see at the specific angle that is pathognomonic for aspergillosis, so they can show you a slide and to be able to diagnose it and recognize it on pathological slide. Rhodococcus equi, I just want to mention, is a gram-positive coccobacilli. It's really a TB-like presentation, but the AFB smears are negative. I guess that's the best way for you guys to remember it. Can cause cavitary, nodular pneumonias. About half of it is extrapulmonary. As you remember, tuberculosis, 60% of tuberculosis in HIV patients is extrapulmonary. It's not in the lungs, so it follows the same pattern. It has a 2/3 mortality, and you have to use at least 2 to 3 drugs to treat it. Anything from vancomycin, imipenem, aminoglycoside, cipro, rifampin, or erythromycin. And try to, based on the sensitivities, try to combine at least 2 or 3 drugs together. Appearance again on imaging studies would be very difficult, and it's again going to be based on a patient's CD4 count if they are able to mount enough of the immune system to cause an infiltrate. That's how it looks on a plate. So it's just a non-infectious pulmonary disease. I do not want you to get tricked, just like I mentioned again, because you are taking infectious disease boards, some of your answers will be non-infectious. Again, don't forget Kaposi sarcoma, lymphoma, interstitial pneumonitis, lymphocytic interstitial pneumonitis, BOOP, and pulmonary embolism. There were questions on my boards. I had one question about pulmonary embolism, and that was the right answer.